One point that you made that I thought was quite interesting is that psychiatric nurses, or nursing in general, we don't have to ask permission to do this and become part of this model. Could you address a little bit more about how we can take our place in the integrated healthcare model?
We have to understand that the Affordable Care Act gave us a lot of permission to expand our role, expand our model of care within integrated healthcare. And it didn't eliminate the insurance companies or Medicare or Medicaid. It didn't provide one payer system. But we have a ability, because of the Future of Nursing document and the LACE, making it a little bit more consistent in our education, and our roles are more defined and evolving towards more legislation, that psychiatric nurses actually can open up a practice. And we can then, apply for status within an insurance company as a company that then would do integrated mental health. I did this 18 years ago when we didn't have these laws. And that was primarily because I was, at that point, a clinical nurse specialist, and clinical nurse specialist legislation really reflected, our role reflected more of an independent and autonomous role. And nowhere in the legislation that and we investigated it for many years, nowhere did it say that I had to work for a physician. And that hasn't come up at all. And I would know this because of some of the work I do with Magellan's Provider Review Committee. We have the ability to open practices and employ other clinicians underneath us. In some states, we are limited to have independent contractors underneath us, especially psychiatrists. Psychiatrists in some states can't work for nurses. But psychiatric nursing has the opportunity to demonstrate our full scope of practice if we can organize and advocate a consistent and clear message, and not to legislators, but to the insurance companies. And we do get Medicare, but we don't get Medicaid. In many states, Medicaid is limited to nonprofit funding or other smaller caveats of the laws that limit our scope. But in most cases, you just work for a clinic group, and that's the way you get around it. You work for somebody to get that, or work for a foundation that's nonprofit, and then you can get Medicaid. But we do have a clear pathway that we can now investigate about opening practices and actually employing independent contractors to go into integrated settings. It doesn't have to be you; it can be other people. We also have we also know that healthcare is now evolving, and if we can use this opportunity to update and deliver new models, it can be more effective in that are more effective in mental health impact on medical issues. We'll get a lot further. So by evolving our healthcare, by using models, I think that we'll be able to get something much larger in the future. Mindful care is a model that I developed. I presented at APNA conference, and you're certainly welcome to go back. It's available on podcast and listen to it. But the key thing about mindful care is the fact that I decided 5 years ago that we needed to demonstrate how medical and mental health interact, and that how we assess a patient is one way, and we needed to provide a whole person assessment, not just a mental health assessment. And in the medical aspect of it, which is the M, medical and mental health, two sides of the brain, two sides of an issue. The medical and the mental health are co-occurring issues, and we need to show their diagnosis and also the impact on each other, how they impact, and then how it impacts on the identity of the patient, how in the context of who they are and how they function, and how the medical or the mental health illness then affects function in the family, function at work, function in their sexuality, in their sleep, variety of identity. But the key piece of this is nutrition. Nutrition and exercise are the key to health promotion programs for persons with serious mental illness. There's a document that came out last year from SAMHSA that had a summary that was really very dramatic. It said that obesity and sedentary behavior are major risk factors for cardiovascular disease, diabetes, and reduced life expectancy. And over 42% of adults with serious mental illness are obese. Fewer than 20% of people with schizophrenia engage in regular moderate exercise, and people with schizophrenia consume fewer fruits and vegetables and more calories and saturated fats than the general population. Now, just those two statements illustrate that nutrition is key to managing the whole brain and understanding how people work. Now, other studies have shown that vitamin levels contribute to depression and other mental illnesses, and insomnia with melatonin levels. People need to readjust their sleep cycles. So there's a lot of different things that we now know that are psychiatric nursing interventions that we now can use, and that's incorporated in this. Another key point of this is the developmental age and stage related to the stage of life that the patient's in. So not everybody who is 18 functions like an 18-year-old. There's a lot of developmental growth, retardation, or advancement, depending on who they are, and that doesn't advance. And also this pays attention to our child and adolescent population as well as our geriatric population about what's appropriate as far as their memory is concerned or their attention span and how to function. And the family system, the unconscious, and the level of functioning is primarily our assessment. So if you break this down again to just do the mind care, it actually is much more congruent with what we can use in primary care, and that's part of it. And the second part of the mindful care model that I put together years ago was the care planning process. And this reflects in the patient-centered medical home principles that I already addressed, is collaboration. You're never treating the patient alone, that there's always the other primary care or providers in the system or the family that you need to collaborate with, and you need to have a clear planning of it, and that is communicated across. The second piece of the care planning process is teaching adaptation skills. Then that's psychotherapy, as well as stress management skills, anxiety reduction skills, even about how to handle themselves socially in that psychotherapeutic skills. The third part of that is recovery. The recovery model is very important, installation of hope, also teaching them that even if you relapse from mental illness or any other illness, it's okay to come back and talk about it. It's okay to get back and into treatment. The brain recovers differently than alcoholics or substance abusers. It's not a definitive recovery, and the levels of recovery might not be a complete brain change, but actually is a process that we actually instill hope and understanding that, yes, we can stabilize, but stressors do trigger them. And the last part of the care planning process is the education, and we talked a little bit about this earlier, and that's really the patient understanding their illness, understanding psychiatric medications, understanding resources and management skills, and that's really a key thing that fits right into what the patient-centered medical home model really values, and this provides it in a very clear way. So that's the model that I worked with, and this was developed years ago with with discussions with some of my colleagues, especially Nancy Hanrahan, who really worked with me originally on this model and really listened to me about where this was going and how this was really going to be fleshed out. And I've never really researched it at this point, but it's a relatively good model to follow at this point. We'll advance that in the future.
Well, thank you so much for sharing your model of mindful care. As we proceed with the development of this role of integrated care for psychiatric nurses, I'm certain that research will be done and theories will evolve that will support the work that we're doing. I'm curious what your thoughts are on how we're doing in terms of developing a workforce to take their place in this model. Could you please address that?
Well, we have developed the workforce with advanced practice psychiatric nurses. The clinical nurse specialist as well as the nurse practitioner both have extremely good training and scope of practice that is very good for the primary care environment. And we really have to continue developing it further, especially in enforcing about the fact that we do look at the whole person. There are changes in the mental health approach in the community, it's much more focused on prescribing and not psychotherapy. So a lot of our professional colleagues who are just psychotherapists might feel left out. But there is some very important places for it. One area I do want to bring up is that psychiatric mental health registered nurses, and these are primarily RNs with associate's degrees as well as BSNs, and these are generalists. We need to get out of the hospitals. There's much more to be done in the communities than just the hospital work that we've been doing. And behavioral care managers have been used across the country in demonstration models as providing early assessment, behavioral intervention, psychiatric triage in primary care. And I firmly believe that if it was up to me, I would have a psychiatric BSN in my office right now. But unfortunately, the reimbursement is not it's not a funded position. Even though they're licensed and they're able to provide and their scope of practice exists, the insurance companies don't recognize them in mental health. They might, in the medical side, acknowledge the fact that RNs and BSNs have a purpose in healthcare management, but they do not on the behavioral side. And that's something which even this morning I was able to write an email saying, is there any funding for a BSN? It's very, very key to the future of understanding that. And one of the things that I want to bring up is what a psychiatric care manager actually does, because then you would be able to see that this is a firm place for our graduates and to perpetuate our profession. Psychiatric care managers consistently monitor psychometric scales for patient and mental health, understanding what the mental health symptoms are so that they can be reflected in the assessment. They also monitor the BMI, the blood pressure, the waist circumference, and the weight, and calculate that in a consistent way so we can track and trend whether or not a patient has some effects of some of the medications that are prescribed or have some obesity issues that might be causing the mental illnesses or other parameters. They also can ensure that the lab values are done and charted consistently, and that's for the CBC, the metabolic panel, thyroid, vitamin levels, and psychotropic blood levels, making sure that they're done consistently. And they also can make sure that EKGs are done for QT irregularities to make sure that patients aren't given medication that actually can cause heart attacks in that individual. And also do EKGs for patients who are taking psychostimulants so that ADHD does not cause irregular heartbeats. And also they can witness the urine drug screen since nobody else wants to witness them. In addition, they also can refer to other mental health professionals for psychotherapy in groups, and also the community-based services that I described earlier. A lot of bachelor's level psychiatric nurses do smoking cessation groups, and they're excellent at providing the medical as well as the psychological support and interventions that are desperately needed in that population. They also can collect data regarding how a patient's doing and show overall outcome studies. They can coordinate the care with the primary care doctors in more complex cases so that the advanced practice nurse can actually do the psychiatric assessment and move on and know that at a certain date and time we'll get back together. They can actually coordinate the appointments for the complex cases. And they can also provide injections for naltrexone and atypical antipsychotics, and do triage of acute cases so that we spend our time with the right psychiatric consults, the people that are needed.
Okay, thank you. I have a comment to make there. I think it's really important, the point that you make about registered nurses need to think of different ways to work, particularly outside of the hospital. And I don't think that we tend to consider registered nurses in the integrated care models and in integrated care settings. One area that has been explored in some depth is that as advanced practice nurses getting out there and being part of this integrated care. Could you address that?
The advanced practice nurse does a little bit different. They do a higher level than what the bachelor's level or the RN level of care manager. They provide psychiatric and substance abuse assessments and treatment. They order and evaluate lab studies and EKGs. They develop care plans for the whole team. They address co-occurring symptoms and management to improve outcomes. And they monitor mental health symptoms and long-term impact on medical problems. This will cut down on some of the medical impact of mental health on the whole person. The advanced practitioners also screens and does brief counseling for substance abuse and prescription abuse. And that helps the primary care have a second side to something, saying, okay, I've noticed you use too much of your prescription medication. Let's screen. Let's go talk to somebody, and let's see what we can do to work together to make sure you get the proper amount of pain medication, and you realize that there's other ways of coping. Advanced practice nurses also coordinate with the team and with outside mental health and behavioral providers and hospitals to make sure that information is passed along between the other levels of service that are available.